The operations chapter is something that is completely different than the rest of paramedic. And understand that it is still 8 to 12% of the National Registry. So there is still importance to actually knowing this material. I'm going to go over some tips and tricks and different things that I think would benefit you in memorizing. But just know that the world of operations is pretty vast and there is a lot to cover. So let's go over some of that stuff. Starting off with the National Highway Traffic Safety Administration, the NHTSA. These are experts from around the country, created the National EMS Scope of Practice. The document provides guidelines for the minimum skills each EMS provider should accomplish. Now, you can see here there are 4 different levels of first responder EMS providers, starting with EMR. And EMR is an interesting one because the emergency medical responder is like a police officer. This is a very basic level of first aid, not a lot to do with medications, anything like that. Once we start getting into the EMTB or the EMT, that's when we start introducing medications, to a little bit more education and training. From there, we go to the AEMT, the advanced EMT, and with this specific certification, they can start administering IVs. They start to get a little bit more medications. Then you got the road docs. If you're reading this book right now, you're trying to become a paramedic, best job in the world. Jumping into EMS operations. Medical direction or oversight. Every service must have a physician responsible for overseeing clinical and patient care aspects. Know that a physician is hired by fire departments and EMS agencies to create the protocols that those paramedics are able to perform. Remember, this medical director is not only responsible for those protocols, but they also oversee the operation. There are only a couple people that can honestly fire somebody in a lot of EMS agencies, including fire departments, and the medical director, believe it or not, is one of them. And when I say that, I don't want you to think that medical directors are walking around firing people. No, but they can, if they don't trust you with their license, then they can ask to get you removed. First thing that we want to look at here is online medical direction. It states when medical direction is given in real time to an EMS service or provider, either by radio or other electronic communication. So whenever you are trying to obtain medical direction on a call and you're saying, hey, should we do X, Y, and Z? This is the patient that we have. And you're speaking to someone, that is called online medical direction. Let's take a look at what offline means. Also known as indirect medical control is medical direction given through a set of protocols, policies, or standards developed by or with the approval of the medical director. So again, this is your protocol book. It's what they say is, hey, I trust you paramedics to do these procedures for these types of patients. It's in writing. No, go off and do it. I don't need to be there to help you do it. This is why we train. This is what we practice, our protocols. Next is standing order. Protocol or guideline, that's a written document signed by the EMS system's medical director, which outlines specific directions, permissions, and sometimes prohibitions regarding patient care that is rendered prior to contacting medical control. So a standing order, it's the protocol. It's what all paramedics are following. Here's something that I'm very passionate about in my organization is CQI, or Continuous Quality Improvement. This is a system of internal and external reviews and audits of all aspects of an EMS system. Know that EMS agencies have a CQI that reviews data and reviews reports to ensure that good documentation and good patient care is taking place. Now, most CQI occurs with the medical direction and or people that are involved in the organization. That's by performing CQI in these meetings, they can determine how many medications are being pushed, if protocols are being followed correctly, or they can see what kind of trends are happening in a community, and that kind of stuff can assist with developing training for providers. Next, looking at CISM, or Critical Incident Stress Management. This is a system that's used to deal with stress on the job. It educated and provides resources to first responders along with other professionals that are involved on a stressful call. Typically, if CISM is called, there's going to be a group of staff that comes to assist to discuss a incident. Now, this incident has to be something that is pretty severe, maybe an MCI, maybe a pediatric fatality. It could be another injury of another responder. These type of high stressful calls call for CISM. Now, when these meetings are called, sometimes they bring a therapy dog, there's peer-to-peer support. So there's other providers, maybe from different organizations that come in. And I've even seen chaplains, so religious figures who come in and that can talk about religion. Now, I don't want you to think that all CISM is about religion, because it's not. But some people, they like to talk about different things to help them cope with serious incidents. It's a good thing. And I don't think it's been going on for that long. And I think research has shown that CISM has been pretty helpful with responders, and it does limit PTSD out in the field. Moving along to safe lifting. Use your legs, hips, and gluteus muscles and contracted abdominal muscles when lifting a patient. Do not use your back. Bending at your hips and using your back muscle will put you out on disability. It states here, do not twist or bend at the waist. Keep the weight close to your body, no more than 15 to 20 inches away from your body. This will help with not bending and putting a lot of pressure on your lower back. Keep your back locked into a normal curvature. Push rather than pull. Lift the stretcher, always with palms. I recommend reviewing some lifts and carries. Some of them might be a direct ground lift, multiple rescuer lift, a direct ground lift, direct carrying, extremity lift, draw sheet method. There's a lot of different types. Here's a couple that I think are worth noting. The straddle slide, possible spinal injury. This is when you have multiple rescuers and you're trying to get through a tight space. Not always are we able to get the stretcher into the house. So we might have to do a straddle slide where we straddle the patient, and it's a slow move, but this is one way that we can get someone out of that house. Another thing that we can do is a close or blanket drag. This one is pretty common, again, when we're unable to get a stretcher into somebody's house and if somebody is very heavy. States here, this is a one rescuer dragged head first, possible spinal injury and risk of danger to the patient or rescuer. Again, if this person's really heavy, obviously that's a risk to me. So I would rather do a blanket drag to assist them out. Next one, extremity carry. This is when they do not have a spinal cord injury and one person's grabbing the arms, the other person's grabbing the legs, and we can move somebody pretty quickly with an extremity carry. Review patient carrying devices such as stair chair, scoop stretchers, wheeled stretchers, portable stretchers, and Stokes basket. This photo right here is a Stokes basket. Stokes baskets commonly are seen in exams, and they're always talking about rough terrain. So remember, in this Stokes basket, you can actually put a backboard in there with a patient on it. It has a lot of straps, and they go in an X formation, usually across the torso and across the legs. Jumping into violent scenes. Stage if not on scene, call for law enforcement, and retreat if you are on scene. Please know the difference between cover and concealment. The first one, cover, is known as protection. Physical shelter or protection sought by people who are in danger. That is the definition of cover. Concealment means the action of hiding something or preventing it from being known. So if you need to hide from maybe a dangerous situation, that is considered concealment. Talking about documentation is another popular thing in operations. The patient care report is a legal document. You're going to hear me say that several times. This must be complete, accurate, concise, and legible. Understand, nowadays they are EPCRs, electronic patient care reports, and that makes things a lot better, not only for us, but also for our agencies to gather data. Functions of PCRs, it shows the continuity of care. Remember, if you didn't write it in the patient care report, was it really done? It might have been done, but guess what? You're not going to know 10 years later from this call, right? So remember, the continuity of the call is dependent on what you write in that narrative. It's a legal document, again, educational, administrative, research, and quality improvement. Remember, these patient care reports are gathering data, and this data is being used by your organization to research and improve their services. Do not change, cross out, black out, white out if you've ever made a mistake or error on your PCR. Like I said before, we're using ePCR, so it's a lot different. I'll talk about how we fix that. But in the case that you're using paper reports, always mark a line if you make a mistake, a single line, write the term error next to it with your initials, the date, and you can then enter new information after. If you are reporting on an ePCR, and let's say you do make an error and you submit it, it's already sent to your agency, and your agency maybe has already sent it to the hospital. Now remember, this is a legal document. You can't just say, hey, give it back. Let me go ahead and change things on there. No, that's not how things work. Let's say that it was an altered mental status patient and you forgot to put a BGL or you forgot to put a stroke assessment. This is when we need to add an addendum. Now, you might have said, I did the BGL and the BGL was 118. Well, guess what? When you add an addendum, it's just going to add another line on the narrative. It's usually in italics, and you're going to write whatever you missed on that ePCR. Because remember, it's a legal document, so it's going to show that something was added after the fact, but it's still your report. You can't just change and alter things once it's submitted. Something that I think has been drilled into people's heads during EMT school is HIPAA. Health Insurance Portability and Accountability Act. This has everything to do with confidentiality. So with this confidentiality, we're allowed to share information when it has to do with patient care. If I go to the hospital and I need to talk to the ER staff, I can tell them her name, the patient's name. That's fine. But when I get back to the station, I am not saying the patient's name over my social media and sharing things about this person because that's confidential, right? That whole transport, it's all protected by HIPAA law. And this is how some providers do get in trouble when they take out their phones and they film and they do different things. This is a lot of HIPAA violations can happen and you can actually lose your license. So be careful. Here's one that every responder loves, EMS Communications. Now, the Federal Communication Commission, also known as the FCC, is responsible for the licensing and radio frequencies that are in the air. Okay, they monitor these frequencies and establish standards for equipment that is used for radios. So let's talk about some of that. First thing is a simplex. So that's the first term I want you to memorize, a simplex. Think about when you were a child and you had a little radio and you keyed it up and you were talking to your friend, and while you're talking, your friend cannot also talk at the same time, right? One person has to be listening, one person has to be sending the message. Receiver, transmitter, right? This is known as a simplex system. Now, when you think of a duplex system, think of something that I can speak to I can call somebody, I can talk, and they can listen and they can speak at the same time, and information will go both ways. So that's a duplex. Now, even better than a duplex is a multiplex system that can transmit other data, text, videos, photos, graphs, right? A multiplex system can send a lot more stuff. Even our monitors nowadays can send different telemetry, and now even in the hospitals, they have biotelemetry where they can not only talk to you, but then they can also receive data from our ePCR. They can receive data from our monitors that send an EKG rhythm. There's a lot of different data that gets shared, and that's considered a multiplex. Now let's take a look at this chart. The first one says a base station. Now a base station is a radio that doesn't move. If you ever go into a firehouse or any EMS agency station, there might be a base station sitting there that you could press a button and you could talk over the radio. Now, why would a base station be somewhere? Maybe because if portable radios go down or you have an issue with a portable radio, there's always going to be a base station at the station. A mobile radio gets often mixed with portable radios. What a mobile radio is it's in the vehicle. So if you go into an ambulance in the front cab, there's going to be a radio that's mounted in the vehicle. That is a mobile radio, not a portable radio. The portable radio is what the provider is wearing. Often you'll see in EMS, we wear a strap, or in the fire service, or they have it clipped to a belt. Next, talking about a repeater, these radio frequencies that are used in EMS are pretty short range, believe it or not. It's called a UHF frequency, which we're going to be getting to here in a second. And because they are short range, there needs to be a repeater to repeat that frequency to push it longer distances. So if you've ever been driving down the road and you see one of those tall cell towers and there's a bunch of stuff on it, and of course lights are flashing, there is not only cell service that's being provided off of those towers, but also there's radio frequencies and repeaters. So one thing that I want you to think about when we think about radio frequencies, think about when you're in your car and you're driving and you listen to a radio station. I'll use an example. 104.3 is a radio station that's in where I live, and 104.3 is considered a VHF, very high frequency, that goes very long distance. Now, obviously, businesses that are broadcasting radio, they're trying to reach as many viewers as possible. So, of course, they're also repeating that service, but VHF, the problem with VHF, and the reason why we don't use it in EMS or first responders is because it's easier to have interference with VHF versus UHF. UHF is a lot tighter of a frequency, has less interference, but it goes shorter distance. So repeaters are extremely important for the use in first responders, EMS, and police. And that is how we are able to talk in multiple cities, or we can drive for very long distances and remain with radio contact. Now, I have seen some type of test questions that talk about different responses. What would you say to this patient? What does reflection mean? These are all different good ideas to think about and really to make notes of. Hopefully, it'll help you answer some questions. Now, I'm going to go through them pretty quickly. Here we got facilitation. It says, encourage the patient to give you information about what's going on. The example says, I'm listening. Please continue. You have my attention. You're just facilitating the conversation. Hey, you have my attention. You're performing active listening. Sometimes even just nodding shows that you're acknowledging whatever they're saying. Reflection, repeating what the patient said. The patient says, my head hurts, and you just repeat it. Your head hurts. It's also showing that you're performing active listening. You understand what they said, and and you're just reflecting it back to them. Sometimes by reflecting, you can also keep the patient on track. Empathy. I always say empathy is a buzzword in EMS, often seen in interviews. What is empathy to you, right? Putting yourself in the patient's situation, or a common one is putting yourself in their shoes. An example of that might be, that must be very difficult for you. And sometimes it's hard to say, oh yeah, I know what you're going through, because you don't know what some of these patients are going through. So just being honest and saying that must be very challenging for you is being honest, and that is showing empathy that you do care. Here's a weird one, silence. Stop asking questions. See if the patient will talk. It says stay quiet and see if the patient is going to speak. Often this is seen in maybe behavioral health. Can also be, and sometimes patients get really frustrated. Obviously, this is a big emergency for them. Giving them a little bit of room and not bombarding them with questions is sometimes beneficial for that person to gather their thoughts and provide you with information. Next, we got clarification. When you don't understand, so you ask the patient to explain further. So the example states, you stated you were allergic to peanut butter. Well, what happened when you ate it? Clarification is something that's very beneficial as a paramedic, because I am trained in medical, right? So sometimes a patient will be talking and they have a difficult time explaining things to me. So I might clarify to them just to get a little bit more information so I can better help them. Next is confrontation. Confrontation can be a little bit of a bad thing. Making the patient aware that you're having trouble believing what they are saying. You said your neck doesn't hurt, but you keep touching it. You can see how confronting somebody might make it confrontational, and they can take things the wrong way. Interpretation. If you're unsure what the patient's telling you, you may need to repeat what you think they said out loud. This is considered interpretation. Here's an example. You said that you fell and hit your head. Did you actually lose consciousness? So they might not have said, I lost consciousness. They may not have said certain things like neck or back pain, but you are going to say it out loud because you're trying to interpret where they're going with it, and maybe giving them a little bit more details might help them jog their memory and may even assist with communicating with that patient. Last thing, and the easiest, probably the easiest, well, maybe not easier than silence, but summary, organizing what the patient is saying in simple form. Recap what the patient explained to you, making sure that all information is correct. This shows that you are a good communicator, and this is a good way to speak to patients. Unfortunately, as a paramedic, we do have to deal with legal and ethics. It's hard for me to say it's unfortunate that we have to deal with ethics. Of course, we have to deal with ethics, but the legality of things, it can get messy if you're not following the rules. Starting with consent, let's look at express consent. Verbal or written has to be of legal age, mentally competent, and conscious. So whenever we get express consent, the first thing that I always do is I say, ma'am or sir, I'm going to ask you a couple silly questions. Do you know where you are right now? What's your name? What year is it? Who are we? I say little things like that. If they're able to answer my questions appropriately, then I am able to give them informed consent. If they want to refuse care, I'm able to get more information, and this is how I can determine if they are in the right mind. Now, an express consent can also be something like I look at somebody and I say, hey, what's going on? My name's Mike. I'm finding out what's going on with them. I say, hey, I need to get a blood pressure. And they reach their arm out. Now, even though they didn't verbally tell me to do so, they're also expressing with body language. That is a form of consent, and we're allowed to obtain a blood pressure. We can't just put our hands on people if they don't want us to. Next is informed. Voluntary agreement to be treated after being told about the risks and benefits and nature of illness or disease. So we need to inform the patient to obtain consent. Can we treat you with medications because you're experiencing this? And if they say yes, then obviously we can do so. We don't just throw things on patients because that is technically illegal and we can get in trouble for that. Implied consent, minors, unconscious, mentally incompetent, or impaired. If somebody is unresponsive, I would think that they would want me to assist them. That is considered implied consent. If I'm running on a car accident and the patient is drunk, they are unable to make decisions. They may tell me, hey, I don't need your help. Well, if they are under the influence and I'm saying that they are impaired, they cannot tell me no. And if they do and it becomes an issue, I'm going to get the police involved. It's implied consent. Now, here's an interesting term, in loco parentis, in place of the parent is what that refers to. Such as a school administrator, sometimes we run calls at elementary schools where the child doesn't have a parent there, and we try to get the parent on the phone, but sometimes they're at work and it's really challenging to get a hold of somebody. Well, this law allows that the caregiver or the teacher or a school administrator can now make decisions for that child. They'll even jump into the rescue with us and go and assist with the transfer to a hospital. So they act as the parent, and that is completely legal. Involuntary, if the patient's under arrest or mental health issues that we can prove. Mental health issues are the hard ones, right? Because sometimes patients, even though they have mental health issues clinically, sometimes they're sane enough to answer all of our questions appropriately. They tell us, hey, I don't want your help. But we know that this patient does suffer from mental instability. Involuntary gets a little bit weird. My recommendation is have police involvement, and that will keep you out of trouble. But if the patient is under arrest, obviously they're unable to make decisions. This is considered involuntary consent. So here's some terms that are legal must-knows. The first one is a scope of practice. The scope of practice is described by the state. It permits the EMT or paramedic practicing under a license or certificate of what they can do. So the scope of practice describes what a state permits an EMT or paramedic practicing under a license or certification on what that provider can do. The scopes might change depending on the state, so please understand that. If you have a scope of practice, it is your job to abide by that scope. If there's something outside of your scope of practice, it could be a skill, it could be a medication. You cannot do that, or you cannot administer that medication to a patient because it's beyond your scope. Even if you know about it, if God forbid something happens, you are now legally liable because it is beyond your scope. Standard of care, following the rules, laws, protocols, textbooks, and national curriculum. Remember, there are paramedics all over the nation. There is a standard of care. Right now, you are studying for the National Registry to prove that you know the standard of care. If you pass this National Registry, that is just proof that you know the standard of care. Now, let's say that a couple of years go by and you do something that hurts someone. They are going to look back at the standard of care and say, hey, would another paramedic around the nation do the same thing you did? If the answer is no, guess who's in trouble? You. Next, we got to talk about duty to act. Duty to act and Good Samaritan Law are pretty interesting because duty to act says that you have a legal obligation to provide service. If you are working, you are wearing a uniform, and something happens, you cannot just turn around. You have a legal liability to go and assist. That is your duty to act. You run a call, you show up on scene, and you don't do something, you are negligent. Now, the Good Samaritan Law states that any person, including those who are licensed to practice medicine, who gratuitously and in good faith renders emergency care or treatment, shall not be held liable for any civil damages as a result of such care or treatment. What does that mean? That means if you're off duty, you're not wearing a uniform, you're not going on a call, but something happens in front of you and you go to help, and God forbid you hurt somebody or something goes wrong, you are not legally liable for that. You are covered under the Good Samaritan Law, showing that you are trying to act in good faith. So it's a good thing. I think everyone should help when they can. Could you imagine if Good Samaritan Law did not protect firefighters, paramedics, nurses, doctors? No one with special training would ever help anybody. Everyone would just look and be like, I'm not getting sued. So this is what has to be put in place to protect people like us. So here's some more Roman, res ipsa loquitur. I don't even know how to say that, but it is a term that is used in law that says the thing speaks for itself. I hate to say this, but this means that the evidence is here. What do they say? The proof is in the pudding. So there's evidence that you messed up. Maybe it's on video. Maybe there's something that they can prove. If the evidence is there, it states here the burden of proof falls on the EMT or paramedic, not the plaintiff. So if that person is trying to sue an EMS agency and they have some sort of evidence that shows that you were negligent, then there's nothing that can protect you, and that's what this law is there for. Next terms, malfeasance. Know this term, performing an act that is illegal. Mal, I always think mal in Spanish means bad. Malfeasance, performing an act that's illegal, causes physical harm or completely wrongful. You can see how this can be considered negligent. Next term is misfeasance. Misfeasance is an act that is legal, but performing it improper or wrongful. So you're doing something that maybe you should be doing, but you do it incorrectly. That's considered misfeasance. Nonfeasance is failure to perform an act that is required by law. You just don't do it. Another form of negligence. Next, we got to talk about libel and slander. Libel, it says injuring reputation by false or malicious writing. Anything that is considered libel might be something you say on social media, through an email, through something that it becomes public. You are putting somebody down. You are performing defamation on somebody's good name. That is considered libel as long as it's in writing. Slander is the same thing, but spoken word. So you talking bad about someone and that goes public, that's considered slander, and you can get in trouble for that. EMTALA, also known as the Emergency Medical Treatment and Active Labor Act, required hospitals with emergency departments to provide care regardless of the ability to be able to pay or afford care. So this is a interesting thing that occurs in the United States. I'm not going to get into it. What I will say is that if somebody crosses the threshold of a hospital, it is now the hospital's responsibility to make sure that that person is okay. So if somebody walks in, they have no money, and they're seeking care, they're going to get care. That is an EMTALA rule. Negligence, I've already mentioned this term multiple times. Negligence is failure to exercise the standard of care that a reasonable person or professional would provide in similar circumstances. In the context of EMS, negligence occurs when a paramedic or EMT does not follow their scope of practice or the established standard of care, resulting in harm of the patient. That is considered negligent. Here's a topic we could talk about for a long time. Advanced directives, DNRs, and living wills. It states here the right to make end-of-life decisions for themselves, by themselves. Somebody is allowed to make a decision to say, I don't want to live anymore. That's what a DNR is. It's not saying that they're committing suicide. It's saying that if, in the event I do go into cardiac arrest, I don't want anybody doing CPR on me. DNRs can get very specific. I don't want somebody intubating me. I don't want somebody ventilating me. I don't want somebody performing CPR on me, right? So having this kind of like documentation is very beneficial for us as EMS providers. So I can read the DNR and I can make a decision on exactly how I'm going to treat this patient. A living will might be an advanced directive that gives some additional information. I don't want to have a blood transfusion. I don't want to be placed on a ventilator, right? These type of decisions must happen from the patient. They must be conscious, they must be aware, they must be alert, and it has to be on a legal document in writing. This is considered an advance directive. Now, crew resource management is something I always thought that was a little bit strange in operations, but believe it or not, it is part of the standard, EMS standard, I guess you would say, and it is something that was made from the U.S. Air Force. Look at what it says. It's an operational practice designed to enhance teamwork and reduce preventable errors, and involves all members of the crew in decision-making and flight safety. Again, this was made by the Air Force. So look at the 5 principles, and I think you need to know what these 5 principles are. I would memorize them just in case CRM does get brought up on your exam. So the 5 principles of CRM is situational awareness, teamwork, effective and improved communication, decision-making with input from the entire crew, and then the last one is equal and divided workload throughout team members. Now, obviously, all 5 of these principles do sound like a great way to have a team function. And we all know that in EMS, it is not a one-person show. It requires teamwork. So this is probably why CRM is a thing. Let's get into some ambulance operations. States here ambulance drivers must have a driver's license. Shocking. Have taken approved driving courses such as EVOC. Have something called due regard for safety. Obey normal traffic laws if you are in a non-emergency mode. Remember, due regard. You are not in control of the road. I don't care if you have your lights and sirens on. You don't own the road. If somebody else has a green light, technically, they have the right of way. Even if your lights and sirens on. If you guys get into an accident, guess what? It's your fault. This is what due regard is. So we have to drive very defensively. Look at what it says here. Drivers must stop if a school bus arm is down, even if the bus driver is signaling you to go around. Also, you must obey school zone speed limits along with railroad crossing gates. So, you don't get any special abilities when you have lights and sirens. You're asking for permission when you're driving through the streets. When you go to an intersection, you stop, you look both ways, you get eye contact with other drivers, and you wait until it is safe for you to enter an intersection, especially, obviously, if you have a red light. You have a green light, just drive as if it's normal, right? NHTSA collects data on ambulance crashes. So if there's ever a question asking who is gathering this data, it is that National Highways Traffic and Safety Administration. So ambulances have changed over the years, and I want you to see these three different types of ambulances. The first, type 1, it says the patient compartment is a square box, which is that patient compartment there in the back. A pass-through window, which I've always liked, where you can just kind of talk to each other between the front cab and the back cab. And it says, look at what it says there at the end, truck style front end. It is so important that you understand that. If you look at that photo and you see that FDNY rescue there, it shows looks like a pickup truck. On the front end, there's a pickup truck. Please remember that. Type 1, pickup truck. The type 2 is a van type. Van types are very commonly seen in like private ambulance companies. Type 3, it looks very similar to the type 1, but it has a van front. So just pay attention to the front end. And you see a box chassis where the patient compartment is, all I want you to do is look at the front end of the cab. If it looks like a van, that's a type 3. If it looks like a pickup truck, it's a type 1. When operating an ambulance, obviously, safety, safety, safety. Look what it says here about kids. Must put a child in approved seats and restraints. Never transport a child on the adult's lap. Never transport a child on a multi-occupant bench seat, even if the child is in a restraint system. Even with minor injuries, the child needs to be in a car seat. Now, it's very common that officer seat, let it be a lieutenant or captain's chair, whatever you guys call it in that agency, has some sort of child seat. Like you will usually convert into one. If you don't have that, then putting the child into a car seat and putting the car seat on the stretcher and then strapping the car seat into the stretcher is another okay way to transport children. Look at what it says here. Lights and sirens must be used when responding to an emergency. We call this code 3. Maybe some agencies might call this something different. Know this, lights and sirens, not lights and sometimes sirens. If you're driving to an emergency, you must have lights and sirens because God forbid you get into an accident. Let's say you hit something or someone, and then they say, well, we didn't hear you. We didn't know you were coming. It's literally that easy. And then guess who's at fault? You're at fault. It is what it is. But if you have lights and sirens and you are driving with due regard, then you are more likely to be protected. Never back up if you don't have a spotter. A spotter is somebody who's going to be on your driver's side, who's going to be waving, directing you where you're backing up. Spotters are extremely important, especially with these larger vehicles. Reduce speeds in inclement weather. And understand, these trucks are heavy. If you're going to brake, make sure you do it early. This is not your car. Okay, it's going to be a little bit of an adjustment when you start driving these larger trucks. Now, of course, we got to talk about how to park at an MVA. Now, in this photo here, you see that we have a police officer, a fire engine, the accident, and then the ambulance. So look at what it says here. Park at least 50 to 100 feet upstream from the accident scene. This provides a buffer zone that protects the crew and patients from oncoming traffic and gives space for additional emergency vehicles. Always uphill, upwind. What does uphill and upwind mean? If let's say that there's like hazardous material, either a leak from the vehicles, let's say that there's smoke in the air, if you park uphill and upwind, that is protecting you on the scene. Okay, when you park and you get out of the vehicle, you're less likely to be exposed to something that is bad for your health. Now, the last thing that it says here, I have seen test questions about this. Your scene size up begins when you obtain dispatch information, not when you get to the scene. So as soon as you start getting and hearing different dispatch information, you could start developing a size up of what you are going to. You could start formulating a plan. You don't have to get to the scene to start doing that. Now, we can't talk operations without talking about air medical transport. Rotor wing and fixed wing. Rotor wing aircrafts are helicopters. Fixed wing aircrafts are airplanes, jets, things of that sort. The advantage of flying air medical transport is rapid access to remote areas, specialized care, a lot of good things. But it's not all good. Okay, take a look at how many disadvantages we have. The cost, extremely expensive. Weather, environmental related challenges. The patient's condition may not be suited for air transport. Potential for crash. airspeed limitations, altitude limitation, the size of the cabin, and need for a landing zone. A lot of issues that are potential issues for calling and using air medical transport. Let's take a look at this landing zone. It states here that landing zones, the ideal area should be a hard, drop, grassy level surface. The space must measure 100 feet by 100 feet. This is preferred. No less than 60 by 60. Another thing, when you consider a landing zone, do not shine a flashlight up at the pilot. You could always, if you're going to use a light, you always shine it down at the floor. If you're going to use cones, use weighted cone. Pay attention to power lines and pay attention to debris on the ground. All these things are mandatory that you pay attention to when determining a landing zone. Now let's talk about approaching a helicopter. When approaching, the safest way to do it is from 10 o'clock and 2 o'clock. Do not walk directly up to a helicopter. Remember, their rotor is usually going to be pitched, and that can cause a decapitation, something that we don't want to deal with. Whenever approaching a helicopter, it is recommended to wear a helmet. We always want to get eye contact with the pilot, and we want them to wave us in. Even better, I want a flight crew to walk me to the helicopter. I never try to approach helicopters by myself. Another thing, when walking up to helicopters, do not walk up to the back of the helicopter. That rotor in the back will move so fast that you won't even know it's there. And remember, it's going to be loud. There's going to be wind blowing everywhere. Most incidents and most accidents where somebody does die usually occurs at the tail end of the helicopter. If we are to walk up to a helicopter on a hill, please approach it from the downhill side. Do not go from the uphill side. Obviously, if you go from the uphill side, they're more likely to be hit by that rotor. Now, of course, here at the end, it states, consider air transport for time-sensitive patients, strokes, MIs, traumas, scuba-related incidents, venomous snake bites, etc. Any patient that requires timely treatment must be considered for air medical transport. Now let's go ahead and take a look at hazardous materials, or hazmat. Hazmat's defined by the DOT. The DOT is Department of Transportation. It's known as any substance that is toxic, poisonous, radioactive, flammable, or explosive and causes injury or death with exposure. None of it sounds good. NFPA 704 created a placard system. Okay, this is a diamond-shaped symbol placard that is on buildings to identify dangerous materials. And you can see it right there to the right-hand side, and obviously right here in the middle. There is that blue color, red, yellow, and white. Now, blue is health hazards. The red is fire hazards. Yellow is reactivity, and white is the specific hazard itself. Now, let's take a look at that example that's being shown. We have a number 2, and if you look at that chart, it says that is slightly dangerous to health. On the red, flammable, this is extremely flammable. It says flammable below, 73 degrees? And in the yellow, we have a 1, which just says it's unstable if heated. So maybe it won't be that much big of a deal. Obviously, in a fire, will become a problem. Now we can go ahead and look at the white. White says which specific hazard we're looking at, and it is an acid. Whenever I enter a building and I do see a 704 placard, it is something that we want to note when we're walking in, because that might be part of the call that we're on. Now, it states here that the DOT requires that there are placards on vehicles transporting dangerous cargo. Chemtrec, Chemical Transportation Emergency Center, is a resource available to emergency responders via telephone that will give information for hazardous material emergencies. Think of poison control. Chemtrec is there to answer any sort of information you want to know, not only about the hazardous material, but what to do in case of an exposure. It states here that paramedics are trained at the awareness level of hazmat. There are 3 different levels that somebody can train to with a specialty. Awareness is number 1, operations is number 2, and technician is number 3. When you're approaching an incident, uphill or upwind, you should be alert for signs of hazardous materials. This can include vapor clouds, strange odors, spilled liquids, and multiple victims. Use the emergency response guide, the ERG. It will guide your initial actions. That orange book right there is awesome. Okay, that thing's going to tell you what those placards are. Now, if you take a look at a couple of these placards that you see above me, we have this explosive one with a ID number 1.1D, and I also have a flammable placard there on the right that says 1993. I would just look those up in the ERG. It'll tell me everything I need to know. How long or how far do I need to evacuate? What do I need to do if the person is exposed to the chemical? What is the treatment? Everything I need to know will be on there. Pretty good acronym here for hazmat. RAIN: recognize, avoid, isolate, and notify. Will help you with dealing with hazardous materials. Let's go in and take a look at PPE. PPE is something that is discussed and often seen in exams. Level A through level D, level A being the most extreme of PPE, personal protective equipment. We have full containment, including the SCBA, or self-contained breathing apparatus, is actually inside the suit. In a level B, it is a full contain where there's no skin showing, but the self-contained breathing apparatus, or SCBA, is located on the patient's back outside of the suit. Level C, they're no longer using an SCBA, they're using an air purifier. And then level D, there is no respiratory protection, just gloves, long sleeves, and a helmet. Now, when thinking about those levels of protection, we always need to consider zones. So, for example, let's say that somebody's in the warm zone and they're wearing a level B type suit in the warm zone. As somebody in the cold zone, I should be considering wearing a level C. It is always going to get worse depending on which zone you're in. You always have to listen very closely to whatever the hazmat team on scene is instructing with regards to PPE. Let's take a look at these zones. Cold zone, the safe area, this is where IC, or incident commander, is, and where the EMS will work to treat patients. That's the cold zone. If you look in that diagram, that's what's located in green, furthest away in the area of the incident, but furthest away from the actual hazardous material. The warm zone, this is the decontamination zone. Decontamination typically is going to be performed by the hazmat team, and this usually involves water. So always think dilution. Now, there are some other ways that they can decontaminate, and we'll talk about those. The hot zone, contaminated area where hazardous materials is. In the hot zone, this is usually where I remember I mentioned those different levels of training. This is usually where those hazmat technicians are, and they're actually dealing with the chemical itself. Now, I mentioned to you that we would talk about decontamination. States there's 4 different methods that we can use in the field: dilution, absorption, neutralization, and disposal. Remember, this is usually going to be done by the hazmat team, but we need to understand how to decontaminate somebody in case of a hazardous material incident. Dilution is the most common and easily used in the field. Flushing, using water, dilution. Gross decontamination is removal of all or the majority of contaminated material that is needed, typically done in a shower where they are actually scrubbing that person. Secondary decontamination is removal of any other residual contamination. Now, we always got to think about radiation when we think of hazmat. And radiological principles, it says there's no suits or protective gear that's designed to completely shield you from radiation exposure. It's the unfortunate truth. We're not walking around in lead suits or anything like that, but it states here the best way to protect yourself is a level C and use time, distance, and shielding. Obviously, time means the time limited being exposed to radiation. Distance, be as far away from that radiation as possible. Shielding, have something like a cement wall or a lead wall. This is often used in hospitals to try to not be exposed to the radiation, like from an X-ray. Let's take a look at these: alpha, beta, and gamma radiation. Please know the 3. Alpha is the least harmful. Alpha radiation, states here, does not travel fast or move through objects. It will even bounce off skin. Alpha radiation is not something that we're too concerned about. Now, beta radiation becomes a little bit more concerning. It states more aggressive than alpha, but can be stopped by even a layer of clothing. So if you're wearing long sleeve shirt, your skin will not be affected by beta radiation. Gamma radiation is the worst type of radiation. Faster, stronger than alpha and beta, requires several inches of lead or concrete to prevent penetration of that sort of radiation. And again, this is what you would find in X-rays is gamma radiation. So let's go ahead and look at some radiation emergencies. And the first one here is aplastic anemia. It states it results from damage to the bone marrow stem cells due to high doses of radiation. This damage impairs the bone marrow's ability to produce sufficient red blood cells, white blood cells, and platelets. Radiation exposure can be due to medical treatments, occupational hazards, or accidental exposures. Some signs and symptoms to pay attention to, similar to those from other causes, including fatigue, weakness, shortness of breath, pale skin, frequent or prolonged infections, easy bruising, nosebleeds, bleeding gums, prolonged bleeding from cuts, and even petechiae. If you remember, petechiae is those purple dots in the skin. Treatment: immediate removal of the source of radiation, obviously. Decon the patient. You're going to see that all the time whenever they're talking about treatment for radiation. Oxygen, IV fluids as needed, and supportive care. States here, properly decontaminating radiation exposure has little to no risk on the provider. As long as you're wearing PPE, right? Make sure you're wearing PPE. Make sure you're staying away from that stuff. Oh, this one's pretty long. ARS, or acute radiation sickness, says occurs after exposure to high doses of ionizing radiation over a short period. It damages DNA, especially in the bone marrow, again, and in the GI tract and skin. This condition progresses through 4 stages known as prodromal, latent, manifest illness, and recovery or death. Let's take a look at some of these signs and symptoms based on the different stages of radiation sickness. So prodromal stage begins within hours after exposure. It just includes nausea and vomiting, anorexia and diarrhea, lasting for hours to days. Latent stages follows where the patient feels relatively well. Interesting. The manifest illness stage presents with severe symptoms like fever, infection, bleeding, severe diarrhea due to bone marrow GI damage. Neurological symptoms such as dizziness, headache, and decreased consciousness occur with high dosages. Recovery, if it occurs, involves gradual improvement over weeks to months, but severe cases may result in death within days to weeks due to multiple organ failure. Some treatment, if you guessed decon, probably right. Let's take a look. Treatment focuses on symptom reduction and complication prevention. Initial management includes decontamination and supportive care like fluid resuscitation, pain management, and infection treatment with antibiotics, antivirals, or antifungals. Antiemetics will control nausea and vomiting. Now, you can't talk operations without an MCI, right? So mass casualty incident is referred to an emergency situation that puts excessive demands on the equipment or personnel of that EMS system. Now, I know a lot of organizations try to say, like, there's certain levels of MCIs and it depends on how many patients are there. Well, it's hard to say like an MCI starts at 5 patients, even though that might be how it works in your organization. By definition, if you're only 2 paramedics, a 3-patient scenario or incident is considered an MCI. The first arrival responder will always assume incident command. The incident commander's role is to direct, control, and coordinate the scene and the resources. So if you're first arrival and you are an EMT or a paramedic, your job is to assume command. Then you can go ahead and call additional resources. NIMS, National Incident Management System, a department designed to enable federal, state, and local governments to effectively prepare for, prevent, respond to, and recover from domestic incidents regardless of the cause, size, or complexity. Now, understand that over time, after running large-scale incidents, they've created a system that works. It's called the National Incident Management System, and it includes the ICS. Now, the ICS is the Incident Command System, and it's broken down into these 5 different categories. Think of the acronym CFLOP. Number 1, command can be either unified or single command, which we're going to be talking about. EMS will report to command or the designee. Next, finance. We know money's got to go somewhere, right? Various functions within finance section would include time, units, cost, compensation, procurement. Someone's got to buy the equipment. Someone's got to pay the responders, right? That's the finance officer. Logistics, help support operations, has responsibilities for communications, equipment, facilities, food, water, fuel, lighting, medical supplies, any of the items that need to get purchased. Obviously, finance is the one purchasing them. Then they need to be stored in a location where logistics is responsible for determining which equipment we're running out of, where the equipment needs to go. Very important position. Next, operations, probably the most important position here, other than the incident commander. Treatment officer, triage officer, transport officer, staging officer. So you can see how officers will branch out in so many different ways just off of operations, right? Operations, that section is extremely important. That's the section that runs the incident, who's doing the tasks, who is creating maybe the strategies, the tactics. Now, planning does a lot of strategy as well. The planning section gets weather reports, has 4 units that they're utilizing, known as resource, the situation, demobilization, and documentation. Now, in planning, the planning section, they are the ones that are responsible to say, hey, how much longer do we have of this incident? How can we start the demobilization process? I mean, breaking down the scene. Who gets to go home first? Who goes home last? These are all different things that get discussed in the planning section. So let's go in and look at an open incident. Open incidents state multiple casualties, but you're unsure of their exact location. Think of a shopping mall. You go to a mall for, let's say, an active shooter, an explosion, something like that. Yeah, maybe you know that there's patients there, but where are they? Are they outside of the mall? Are they inside? Are they in a bathroom? We're unsure. That's why it's an open incident. But if it's a closed incident, it says multiple casualties in a contained location. Think of a school bus that rolled with no ejections. If you can confirm that there were no ejections, you know everyone's inside that bus. You could hop into the bus and you can see where the patients are. It's a closed incident. Command staff consists of 3 people that you must know. The PIO, or Public Information Officer, the ISO, the Incident Safety Officer, and the Liaison Officer. Let's start with that PIO. The Public Information Officer supports mental health, collecting data, and releases information to the press. So the PIO might wear several different hats. And if you ever see somebody who is talking on the news, somebody who's typically in charge of the social media, maybe of a agency, usually that's the PIO. That's the person that gets to speak on the news. Safety officers, infection control, PPE use, crowd control, equipment, watching for lifting of patients being done properly, making sure that everything is done safely. There are 2 different people that can shut down an incident, obviously the incident commander and safety. Last here, we got the liaison officer, coordinating with the outside agencies and deploying specialized resources. Incident command is obviously working with multiple agencies in a lot of these large incidents, and they need a liaison officer who's going to go talk to different agencies and come back to talk to the incident commander. It allows for very smooth communication. Let's go in and take a look at the incident priorities. I call this the LIP. Starting with the most important is life safety. When we think of an incident priority, obviously saving people is the whole reason why we're there, right? Number 2 is incident stabilization. You must stabilize the incident before you can conserve property. So property conservation is the last incident priority. Remember, always start with life safety. Remember, LIP. Next, we got single command, 1 person who's in charge of the incident. A lot of decent size incidents that require ICS. Yeah, a single command is okay, but once it starts to involve multiple jurisdictions, maybe multiple agencies, that's when we start to get a more unified command. Unified command means that you have multiple agencies are represented and in command of the area. So, for example, if you have police, another agency of fire, another agency of EMS, and they have kind of like a chief or a command staff member who's responsible for those agencies, they all kind of work in like a unified command system, but they all need to be near each other so they can speak to each other. Last thing on this page, we're going to be talking about span of control. It says the number of people that one person can safely supervise. You should limit the number to 3 to 7. The optimal span of control is 1 officer and 5 responders. I do understand that sometimes span of control can get a little bit challenging in a large incident, but the optimal goal is to have 5 people working along with 1 person who's in charge and creating like different units based off of that span of control. Let's take a look at triage. Triage means to sort or prioritize patients based on their severity. Starting with primary triage, to prioritize based on a rapid assessment on scene. Now, this is the first triage that you perform initially on arrival. Now, I know I said you need to go ahead and establish command. All right, let's say somebody already established command. You have been assigned a triage. The first thing that you jump out and do, and you grab those triage tags and you walk up to patients, you're starting the primary triage, which I'm going to show you how to do start triage here in a second. With secondary triage, it says when the initial triage has been completed, and then you go to do your secondary triage since the patient's conditions can possibly change. And then you could rearrange those color tags. Now, understand something about secondary triage. This occurs in the treatment area. So you triage somebody, let's say you tag them a green tag and you say, go over to the treatment area. Well, when that person gets to the treatment area, there is a chance that that person is now a red. It's possible, right? So they need to be re-triaged, and we call that secondary triage. Let's take a look at 32 can do. This is known as start triage. Primary and secondary, we're going to be utilizing this same exact technique. So let's say you walk up to an incident and there's a bunch of people standing there and they're all part of the incident. First thing I want you to do is say, hey, can anyone in here walk? If you can walk, come to me. People are going to walk up to you. You're going to have those people stand off to the side, and you're going to have one of your partners start triaging these people who are walking. If they are walking and they do not have a respiratory rate of 30, their cap refill time is not delayed, and they're able to follow commands, they are an automatic green tag. I don't care if they broke their arm. I don't care if they have a dislocated shoulder, they have chest pain, whatever the case might be. That person, as long as they don't meet that criteria, they're a green tag and they move on. Now, again, they're still going to the treatment area. They're still going to be reevaluated, and they're still going to obtain treatment. You're just prioritizing right now. Next, let's say that you find somebody who does have a respiratory rate greater than 30, they have a delayed cap refill or CRT, or they can't follow commands, or they're confused. They're an automatic red tag. Those are immediate patients. Let's say you just sent off all those people to your treatment area. Now you're looking at your incident and there's a bunch of people still sitting there. These are people that were unable to ambulate. This means they're either going to be a yellow, a red, or a black tag. You walk up to an individual, you say, hey, what's going on? They tell you, I sprained my ankle. Okay, you're going to count their respiratory rate. Let's say it's less than 30. You check their cap refill time, it's less than 2. Last thing, are they able to follow your commands? Yes, they can. They just can't walk because they sprained their ankle. They are a yellow tag because they are now delayed. They should be a green, but they are delayed because they're unable to ambulate. That's all a yellow tag means. And again, nothing different with the red tags. So there might be people laying down that are confused. They're not following commands. Their respiratory rate's high, or they're in shock or perfusion. That's why those patients would be considered a red tag. Now the black tag. Let's say you find somebody who's laying on the ground unresponsive. All I want you to do, head tilt, chin lift, and look to see if they're breathing. If they are not breathing after you performed a head tilt, chin lift, they're a black tag. If they start breathing after the head tilt, chin lift, they are a red tag. I know it sounds like a lot. It's really not that bad. Something that you should definitely practice. And it's hard for me to guarantee whatever's going to be on your exam, but this is a very common EMS type question. Now, you can't talk triage without talking about jump start triage. Now, jump start triage is for kids less than 8 years of age. And it states here, when triaging children, remember that that age will dictate if they can follow commands. Think of AVPU. If the child isn't completely alert, consider it a red tag. Now, again, depending on the patient's age, some kids there don't follow commands. Like think of a 1-year-old, think of a baby. You think you're going to say, hey, baby, stand up and walk over there, or whatever the case is. No, the kid's just going to stare at you, right? So you got to think AVPU. Remember, alert to verbal, alert to pain, and unresponsive. Same thing that we did with the adults. If you could stand up, come over here and stand right here. Have your partner go ahead and start evaluating these patients. If they have a respiratory rate greater than 45 or less than 15, those are red tag. Again, CRT or cap refill time greater than 2, red tag. They're altered. Maybe they're inappropriate behavior, their posturing, whatever the case might be, that's also considered a red tag. It's technically your judgment to say that this kid is not acting appropriately for their age, and that's why you might have to place a red tag on that patient. Again, if they're unable to ambulate because maybe they broke their foot or whatever the case might be, they doesn't mean that they're an automatic red tag. They could be delayed. They could just be a yellow. Now, one big one that changes is the black tag. So let's say we walk up to a kid who's unresponsive, not breathing. The first thing I want you to do is head tilt chin lift, and I want you to deliver 5 rescue breaths. Now, if you remember what a rescue breath is, it's 1 breath every 2 to 3 seconds. So you're going to breathe 5 times for that child and look to see if they start breathing after you delivered those 5 breaths. If they start breathing, they're an automatic red tag. If they aren't breathing, you're going to label them a black tag and you're going to move on. Talking about WMD, or weapons of mass destruction, states that it's intended to cause widespread death and destruction. Now, this is a good acronym to memorize: CBRNE. That's chemical, biological, radiological, nuclear, and explosive. Those are the 5 different weapons of mass destruction. Nerve agent is it states here, nerve agents are classic chemicals called organophosphates, which I'm going to be talking about, that cause the body's organs to become overstimulated and burn out. Like I said, I'm going to talk about it here in a second. First one that we're going to talk about, though, that is very popular in tests is cyanide poisoning. Cyanide prevents cellular respiration, leading to cellular hypoxia and metabolic acidosis, despite adequate oxygen levels in the blood. Some signs and symptoms here, it includes headache, dizziness, shortness of breath, chest pain, nausea, vomiting, confusion, and seizures. Severe cases may progress to a coma, hypotension, cardiac arrest, and death. Treatments. Immediate treatment involves removal of the exposure, shocking, and 100% oxygen. An antidote is called a cyanokit. I know the hydroxycobalamin. Look for the long word with an H. We always call it the cyanokit. What it does is it binds the cyanide, and it allows the patient to basically excrete it through urination. Supportive care includes managing seizures, cardiac monitoring, and treating metabolic acidosis with bicarb. Now, something interesting about cyanide poisoning is cyanide in exams is often found with a almond smell. That's one way that they talk about it in tests. Another thing is it's in modern fires. In firefighting, they say we have modern fires and we have legacy fires. Well, legacy fires used to be like more real woods, and it would take longer for that kind of stuff to burn. Now with modern fires, we have stuff that's made out of plastic, paints, just other synthetic materials. And that stuff, when it off-gases, it has cyanide in it. So any structure fire or car fire where your patient is considered altered, unresponsive, maybe in cardiac arrest, please consider using a cyanokit on your exams. Now, I told you I'd be doing organophosphate poisoning. Here we go. I know it's a lot, but this is one is extremely important, I promise you. It states organophosphates inhibit acetylcholinesterase. I know that sounds fancy. I'll explain it. Leading to an accumulation of acetylcholine at the neuromuscular junction and excessive cholinergic stimulation. Now, let's talk about acetylcholine. When acetylcholine reaches that neuromuscular junction, that's when the neurotransmitters actually bind to receptor sites and create an action. Well, guess what? The cholinergic response that happens throughout the body is going to cause wild signs and symptoms. Let's take a look at those. It states here, follow the sludge or dumbbells acronyms. So let's look at sludge first. Salivation, lacrimation, urination, defecate, gastrointestinal distress, and emesis. Whatever orifice can have fluid coming out of, it's going to happen with this cholinergic response. Let's take a look at dumbbells. I like this one a little bit more. Diarrhea, urination, meiosis, pinpoint pupils, bronchospasm, wheezing, emesis, lacrimation, and salivation. Additional symptoms include muscle twitching, weakness, respiratory distress, bradycardia, seizures, and even AMS. So a ton of signs and symptoms, and they're so valuable to know those because whenever I'm taking an exam and I see a patient that has wheezing and pinpoint pupils, it's almost guaranteed that is going to be an organophosphate poisoning. Then they throw on maybe bradycardia. If they say anything about urination or defecation, it's already too easy. So I try to look at the more maybe obscure types of signs and symptoms. Some treatments. Immediate decontamination by removing contaminated clothing and washing the skin is critical. Decon. Administer atropine to counteract the muscarinic effects, followed by pralidoxamine to reactivate acetylcholinesterase. We get something called atropinization, where we're giving large amounts of atropine. It's usually at 2 milligrams per dose, and you're giving it over and over, maybe 3 to 5 minutes in between, but you're giving it until those signs and symptoms go away. Another thing is this pralidoxamine, also known as 2-PAM. It's an auto-injector that we can give 3 times, lateral thigh, just like you would an auto-injector for epinephrine, and it's 600 milligrams per dose. So you can give it 3 separate times. States here, benzodiazepines are also used to control seizures. Advancing the airway and ventilatory support may be necessary due to respiratory muscle paralysis. Continuous monitoring and supportive care are essential for recovery. Here's that Mark 1 kit there at the bottom. Mark 1 kits were created for, honestly, I believe it was more created for responders to carry in case they get exposed to organophosphates. But again, it has 2 milligrams of atropine and a 600 milligrams of pralidoxamine. It's in the same kit, right? So easily administered. It can reverse muscle weakness, paralysis, and that duodope. The duodope was just another term that was used where I believe they combined both medications. If I think I'm right about that, where again, it was also used for responders. Now, one thing I do want you to understand about organophosphate poisoning is in exams, they could call this insecticides, like bug sprays and stuff like that. Insecticides are known as organophosphates. So please be careful on your tests and pay attention to the wording. Now, the last hazardous material that I'm going to be covering here in operations is hydrogen sulfide poisoning, the rotten eggs. It states here, inhibits cellular respiration by binding to cytochrome oxidase, leading to cellular hypoxia and, again, metabolic acidosis. Signs and symptoms, rotten egg odor on the breath, headache, dizziness, nausea, vomiting, dyspnea, confusion, loss of consciousness. Severe exposure can lead to respiratory failure, seizures, and death. Treatments, immediate removal from the exposure like all the others, administration of 100% oxygen, supportive care, and in severe cases, take them to a hyperbaric chamber. I know this is a lot of information. Keep on studying, Watch this as many times as you need just to help you memorize these terms and these concepts of operation. I know whenever you take exams, you might see some other different types of questions. So take notes. The more notes, the more repetition, the more tests you take, the more likely when you see an exam like the National Registry, you're going to be prepared for it. Hope this helps. See you on the next one.